All right. Good evening, everybody. I got to admit, it's always a pleasure to speak after Martha or Dr. Murray, and it's always impressive all the hard work that she did and has put into this along with her teams. Certainly, I think what hopefully everybody has left those slides with is how much effort, how much research, and how much knowledge has been put into defining a great way to bridge ACL restoration. I'm going to take some time just to kind of give a little bit more of the post-commercialization view and share a couple cases with everybody to give an idea of how kind of ACL restoration has changed my practice and the journey I've been on since I started. And so just to give a 2024 commercial update, there's been over 2,000 patients that have been treated with the BEAR implant. About 2,500 have been put in overall. And if you look at it, about most of the ones that have been treated within the commercialization phase have been proximal tears. And what that means is Sherman type 1 or 2 tears. And for those of you that aren't familiar with the Sherman classification, that means a avulsion type injury or one where the tear occurs in the proximal portion of the soft tissue ligament. Mid-substance tears are more Sherman type 3 or even 4 injuries that occur truly in the mid-substance. And what's interesting, a lot of the studies that were done initially, including BEAR 2, most of the injuries were actually mid-substance type tears. But as we've seen this kind of transition to a commercialization phase, which a lot of people on this call are either using or treating patients from a therapy perspective, certainly comfortability has come in more of those proximal-based tears initially, but still getting used in the mid-substance tears. The age breakdown is all across the map. We can see it's been used in young patients that are athletes, all the way up to patients over 40, which I fall in that category, where more recreational athletes, weekend warriors, and such. So again, they've been used all across the map. From my perspective, one thing I'll say additionally is if you look at from a commercialization perspective, what do I look like at in terms of tear types? Certainly to me, the location is important, but the quality of tissue is also important as well. Can the tissue hold suture? Can you direct the tissue in the right direction? There's been a lot of research that's been done showing the ACL can heal, just often doesn't heal in the right direction. And so certainly what Dr. Murray and others have shown now is that if we put the ACL fibers directed in the right direction, then often we can get healing by restoring that the mechanism for holding a clot, preventing synovial ingress into the clot area, and providing some stability at that site to enhance healing. So from a patient selection perspective, what I like to go over is kind of where my journey has been and where it's gone. Certainly, I was on a journey for a long time in terms of the ACL reconstruction not being the end all from an ACL surgery perspective. And so certainly as I've done this for the last 10 years, I've done repair and select candidates. And then in the past 2 years, I've been on the BEAR journey from a restoration perspective. So for me, where was a good place to start? And from my perspective, what I looked at was what was a good patient where I almost go into the knee and I feel like I'm taking out a lot of good quality ligament. And so that's definitely that proximal based tear. So when I talk to a lot of surgeons out there and physicians that are interested in trying restoration, I tell them, hey, there's a lot of cases to start with, but getting comfortability is really that patient that gets more of an avulsion type injury. And so you can see here, good quality ACL tissue. You can see a little bit up here that's not intact. So maybe a femoral avulsion, but maybe a little bit more of a Sherman type 2 with up to 20% of the ligament still attached. But you almost go to the other views, the corona, you can almost see lift off of the ligament, maybe just some residual tissue along the footprint with some reactive tissue at the bone itself. And so this is a great patient to start with as you kind of go down this journey, because often it can be a situation where you go in there and you see good quality tissue. And this is what I'm talking about from a clinical perspective. So we can see here a lot of vascular tissue. You can get a sense here that the ACL is buckled forward. This is the PCL for those of you that don't see a lot of arthroscopic pictures. And you can see as I go in here with the probe, I can get a sense my probe's getting in there and I'm lifting off the ligament, but I can see a little tissue, which is really the synovial tissue surrounding the ligament. And as I come over the top of the ligament, what you'll notice is there is a hole within the synovium. And if I kind of press down on that hole, you'll see some of the cyst kind of formation tissue kind of or fluid coming out of that area. So you can see some synovial tissue, but the bulk of the ligament is getting pulled off as I retract it back. So in a lot of these cases, this won't necessarily always heal to the footprint. So a great patient as we start off from an ACL restoration perspective. So from a patient case perspective, I'll go through a few cases. And what's really changed in my practice is almost what's happened to me from a clinical perspective. When I see a patient in the clinic with an ACL injury, my approach is completely different. Dr. Murray pointed out some great information about ACL reconstructions, and it's not the end all be all. And certainly there are complications that happen, and it's not all about re-tear rate. Re-tear rate is one of the components we look at. But how many people have had patients that have had a little bit of nerve finding, stiffness to the knee, quad can't build back up, struggling through the rehab, or subsequently have a reconstruction and re-tear as well? And so certainly as I've kind of gone into the office now and talked to my patients, there's been so much research that's been done on the restoration and BEAR implant that I feel that patients deserve to understand and know that this is an option to treat their ACL. So when I walk into a room, I talk about the COPER program, ACL repair and restoration, as well as ACL reconstruction with 4 different grafts, including the patella BTB, quad tendon, hamstring tendon, and allograft. And as I go down that journey with patients, I kind of listen to them and learn about what are their biggest fears. How old are they? What's their activity level? Cutting, pivoting, and twisting activities that they want to participate in, and really get a sense for what is the patient looking for, what I'm not assuming they're looking for. And so along that journey, I found that a lot of patients are very interested in understanding what the restoration technique looks like and whether or not they are a good candidate for it. When I go down that realm and communicating in the office, I then try to get a sense for, hey, if you do believe restoration is the right option for you, I give them information, have them go home and think about it, and have repeat conversations about whether or not we're going to definitively go down that road, or whether reconstruction is the right option. But every patient I indicate, even where I think an ACL restoration is a good option for the patient, I will always in my consent forms have ACL restoration with the BEAR implant. And then possible ACL reconstruction with whatever graft. Because if I ever get in there, then I have the option if the quality of tissue is poor or it doesn't look like the MRI says. And in fact, some research has been done showing that the pre-op MRIs in these patients aren't always predictive of what the quality of tissue is going to look like or the candidacy from an ACL restoration perspective. And so, my first patient and how I started was a great kind of a great candidate that I showed from my earlier pictures, that was a 65-year-old female with an ACL tear while skiing. And so often a lot of people would say, well, what about just trying to do a COPER program in this patient? And as I discussed before, I offered COPER program. The patient wanted surgery. So this is a perfect candidate of a little bit of chondromalacia, but good cartilage surfaces, a true acute ACL injury, otherwise a good quality joint. And the patient did not want to do a COPER program. And although a reconstruction can be an option in a patient of this age, there could be concerns about that. And so we can see here on the MRI some disruption of the proximal ACL. We can see here on the coronal the same thing. There's disruption at the footprint of where the ACL attaches. And so when I went into the joint, obviously you kind of look at that and you say, well, is part of it intact? Is it not intact? And we can see here it looks good quality. When I duck around the corner, the same thing. We can see the tissue is pulling off the footprint with some synovial tissue intact. And so this shows my drilling on this side. I've switched to a different guide now, and then shows me with the sutures passing and my Ethibond sutures in my setup from an ACL restoration perspective. Now, obviously, it's always, you never want to show cases that just always go smooth. Obviously, there's always some good things to show and lessons learned as you kind of go through these cases. And so this patient went back to Vail. Fortunately, at 3-month mark, did not ski, but fell. And then presented at the Stedman Clinic where they did an MRI to see what was happening. As Dr. Murray showed before, that's the time you get scared as a surgeon, because you're getting an MRI at 3 months. And as she showed very eloquently before, there can be further changes and improved look of the ACL all the way up to the year mark with restoration at the 2-year, or a continued good quality tissue at the 2-year mark. And so I was a little nervous, but even it was interesting. The read from the radiology report was that it was a BEAR implant with the ACL restoration still intact. And we can see here, you can see some of the sutures going through, ACL tissue still intact. As we get to the other sagittal view, footprint that's attached, and we can see almost right here, restoration of the footprint, attaching back in, and this was the drill hole that I had on the femoral side. So healing at that footprint side where there was injury that was previously incurred for this patient. And so now this patient is 2 years out, has returned to skiing and doubles tennis with no issues, which is a great result in a 65-year-old patient that obviously you'd have concerns about, is even surgery the right option? So here's another younger patient because I wanted to show, because my practice has definitely evolved over time. Certainly with elite athletes, I have interesting conversations with the athlete as well as the team and athletic trainers to make sure I get comfortability about doing a restoration procedure. But this was a 19-year-old female with an ACL tear trying to catch a fly ball. She actually had a teammate that had an ACL reconstruction and had a poor result. And so when she came to see me in second opinion, she was very interested in what other options there were. And so as you can see here, definitely not a Sherman type 1 avulsion injury, some injury toward the mid-substance, but maybe a Sherman type 2, could be even up to a 3 type injury. We can see as we roll through the images here, a little bit of tissue attached to the femoral side. And we can see here on the coronal, we can see still a little bit of tissue on the femoral side. So definitely more of a 2 to type 3 injury in a softball player at 19 years of age that plays in college. So obviously one of the athletes that some people might have concerns, given that it's an elite athlete trying to play college sports. So I went in there, showed a similar type injury. You can see the ACL here. I wish I had a view of what it looked like, but it looks similar to before, but there was some tissue coming off the femoral side. Drilled both sides, and this was the setup. You can see some tissue here, but there was some tissue up here off the femoral side. So what you can see actually, oh, that got placed in the opposite direction. So this was the this was the resting position. We can see some tissue here. As I displaced it, you can see it pulls away, but there's some tissue up here. The injury was right here. But as I push it to a reduced position, you can see I have enough length of my ACL tissue to still direct it up to the right spot. And so this was supposed to be the next slide. So sorry about that. This was me doing the femoral position, tibial position, and then the setup. So interesting. The interesting part about this was that she had PT in a very rural Florida county. She was really struggling initially with range of motion. It was a physical therapist that hadn't necessarily worked with the BEAR technique before. At 2 to 6 weeks, I was already trying to get a change in PT site, but the patient declined based on the amount of distance it would take to get to another PT. Finally, at the 6 to 9 week mark, only 5 to 45 degrees of range of motion. So we changed the PT site and the patient agreed. I then went to a more of what I say as a center of excellence, people that have had a significant amount of ACL history and it actually worked with the BEAR technique and saw an immediate pickup in the range of motion. 0 to 90 degrees, then went to 105 degrees, but kind of flattened out at the 4 week mark. Wasn't one of those patients that really felt stiff, but definitely just had some maybe whether it was some anterior adhesions or just didn't feel comfortable moving the knee to more range of motion. So I wouldn't call it the patient had an arthrofibrotic feel to the knee, but more of just a stiffness and a slow recovery. So at 5 months, for fear of not making further progression, I suggested doing a scope and looking at if there was adhesions. And what my feeling is, I never do just a manipulation under anesthesia, status post ACL reconstruction, or the restoration technique, because I want to get in there, lyse adhesions, and not break up any of the tissue, whether it's or stretch out the ACL reconstruction or the restoration. So I did a lysis of adhesions and then made sure I could get the most motion. So some warning signs here, obviously the PT considerations. At the first surgery, you could also see there was some synovitis there. Young female, fair complexion. Sometimes that presents with some of the things that we've seen in the office when patients tend to follow some stiffness. And so those are some warning signs, but also just here, slow progression with PT initially. And so I got a second look at 5 months, and this is the only second look I've had. I've had about 60 patients that I've done the ACL restoration with BEAR technique. But you can see here, vascular inflow into the ACL itself, and here, healing at the footprint site with stable as I was pulling on it. It wasn't pulling off. You could tell before as I pulled it away, it was bowing. And the interesting part here, I didn't see any evidence of any of the sutures that were there before. So after surgery, the interesting part about this, again, not an orthofibrotic feel, and the patient immediately recovered quickly. Within 2 weeks after surgery at the 5.5 month mark, 120 degrees, got up to 140 degrees by 8 weeks, which is 7 months status post initial procedure. By 8 months, the patient had full motion, started hitting a simple fielding program. And by 3 to 4 months after, but 9 months status post the initial surgery, basically was returned to play. So interestingly, as opposed to an ACL reconstruction that really got arthrofibrotic, this patient actually got back on the right path fairly quickly. And you can see here, most of the time when I have an ACL reconstruction, if they are getting stiff, I'm scoping them at 3 months because they get really stiff and then they really suffer. Their quad doesn't build, they get inhibition and develop bad habits. And so I was able to wait longer in this case, but also we're able to make up for it on the end because it wasn't a true arthrofibrotic situation. So ended up it being in a good result. So this gets to my personal experience because I kind of didn't tell the truth earlier. My first real experience with this was actually this, and this is my wife. And so it's interesting whenever you have a family member that suffers an injury, it makes you rethink and question the mentality that you take into how you treat injuries. And so my wife, valgus knee, is not the best candidate from an ACL perspective, never has really spent a lot of time in the gym building quad bulk, things like that. So I knew that it was going to be a tough course after surgery. And so for me, the ability to have another option for her was very important. And you can see her injury. She was a true mid-substance injury, more of a Sherman type 3 injury. For her in particular, had one of the part of the ligament that was kind of coming forward, which was the more anterior medial portion, and the posterior lateral had a little bit more length to it. So a true mid-substance rupture. And you can see her here, probably 9 months after surgery, she was up here, and now she's back to doubles tennis, working out and happy with how she's doing. And no, she wasn't a skier, and she doesn't want to ever go skiing again because that was not in her passion project for her. But it was an interesting start for me, and this was really the first time I thought about, hey, I want a better option. I want another option. I feel like the utility of having more arrows in my quiver is very important to really truly give ACL injury patients options that are going to kind of give them the ability to get back to what's important to them and limit the complications that can happen that, again, are important to them.